Okay, welcome everyone. I'm very excited for the opportunity to introduce our visiting professor, Dr. Hani Jneid, who will be giving us our cardiology grand round speech today. Give me 1 second as I set everything up. Okay, so Dr. Jneid is a Associate Professor of Medicine at Baylor College of Medicine, as well as the Director. Okay, welcome everyone. I'm very excited for Sorry about that. I'm trying to live broadcast this on YouTube for the first time, so there may be some issues. Going back to our introduction. So Dr. Jneid is the Associate Professor of Medicine at Baylor College of Medicine, as well as the Director of Interventional Cardiology at the Michael E. DeBakey VA Medical Center and Interventional Cardiology Research. He is the Program Director of the Interventional Cardiology Fellowship Program and obtained his medical degree from the American University of Beirut Medical School. He trained at Cleveland Clinic for Internal Medicine Residency and the University of Louisville for Cardiology Fellowship. He then received interventional and advanced interventional cardiology training at Mass General. He currently serves as the Senior Associate Editor for the Journal of American Heart Association and has been on the editorial board for the AJC and JAC. He has chaired the ACC AHA Unstable Angina and NSTEMI guidelines and updates, and his scholarly work focuses on interventional cardiology, acute coronary syndrome, and outcomes research. So I'm very excited to hear from our visiting professor with a topic on updates on aortic stenosis and TAVR.
Thank you very much, Joyce. Thank you for the kind invitation, and it's absolutely a pleasure to be with you. I wish I'm with you physically, but even meeting you all virtually is great. So it's a pleasure to be with you. I have a lot of great friends at UCSF, and I know a lot about your excellent work and achievements. I've been collaborating quite a bit with Dr. Yaram from Interventional Cardiology and writing jointly some AHA endeavors and statements. And Dr. Michelle Albert is a dear friend, mentor, and a role model. So I wish I'm there to meet them in person as well as meet all of you. Saying that, today I will be talking to you about updates in aortic stenosis and TAVR in particular, and giving you particularly insight from the 2020 ACC-AHA valvular heart disease guideline. So I was a member of the writing committee of this guideline, which we published in December 2020, which updates and supersedes the prior iteration of the guideline, which was published in 2017, of which I was also a participating writing member. I'm very familiar with AS and TAVR criteria because I contributed to the writing and evaluation of the literature and formulating these guideline recommendations based on the existing literature, expert opinion, as well as the ongoing work in the field. I have no relationship with industry pertinent to this talk. And I want to start by reminding you about the ACC-AHA classes of recommendations for clinical strategies and interventions. You're all familiar with the class 1 indication, whereby the benefits way outweigh the risk, and the treatment, intervention, or diagnostic strategy should be implemented and is recommended. Now, there's also class 3, which the strategy, whether diagnostic or therapeutic, should not be done. And here we have class 3 should not be done because there's no benefit, but also there's class 3 should not be done because of harm. And this is the strongest recommendation for not implementing a strategy. And then there's a class 2A, it's reasonable to implement a strategy because the benefit very likely outweigh the risk, but also there's a weaker class 2B recommendation that it may be reasonable to implement a strategy because the benefits possibly outweigh the risk. Let me start, and by the way, this talk is geared towards the practicing cardiologist, and I'm going to start with a clinical case, simple clinical case that's maybe targeting cardiology fellows, and then maybe escalate the discussion towards therapeutic interventions and maybe topics related to interventional cardiology. So I hope I would cover a lot of aspects related to AS and TAVR from clinical to interventional aspects. So let me start with this case of a 66-year-old man with a progressive dyspnea exertion and fatigue, BNP 310, past medical history hypertension that's poorly controlled with systolic blood pressure of 150 millimeter mercury. He's got a prior CABG as well as a prior mediastinal surgery. So 2 prior surgeries. STS prom score 6.5%, placing him at intermediate risk. TTE showed normal LV ejection fraction, mild LVH, mean gradient of 42 millimeter Vmax across the valve of 4.1 meter per second, and aortic valve area of 0.9 millimeter square. These are still images of his CAT scan. To the left, you can see this heavily calcified trileaflet aortic valve. And to the right, not the best image assessing the aortic valve, but you see a hint of the calcification. And I want you to focus on the apex and think there what's happening in the apex. And I'm going to come back to this apex and at the very end of the talk. So according to the 2020 valvular heart disease guideline, this patient should undergo which strategy? 1, should he undergo an exercise stress test? 2, have optimized the blood pressure before AS treatment. 3, have an aortic valve calcium score measured. 4, receive a follow-up echocardiogram in 6 months. Or 5, undergo aortic valve replacement. Obvious answer to most cardiologists is number 5, but I want to go over all the other options and dissect why these options are not valid and should not be done according to the valvular heart disease guideline. So let me start by reminding you all of the stages of valvular heart disease, and this has classification has been there for some time. So we have stage A, at-risk valvular heart disease patients. For aortic stenosis, that would be patients, for aortic valve, that would be patients who have either aortic sclerosis or bicuspid aortic valve. Then we have stage B, progressive aortic stenosis, and this is usually mild or moderate aortic stenosis. And then stage C, which is asymptomatic severe valvular heart disease. And for the aortic valve here, we have stage C1 and stage C2. C1 is asymptomatic severe aortic stenosis, but with LV and RV that remain compensated, so predominantly normal LV function. C2 is asymptomatic severe aortic stenosis, but with decompensated LV or RV, such as an EF less than 50%. And then you're all familiar with symptomatic severe valvular heart disease, stage D. And in the case of the aortic valve, symptomatic severe aortic stenosis could be classified into 3 categories, D1, D2, and D3. D1 is the most classic, high gradient, high flow aortic stenosis. You've got severe leaflet calcification with fibrosis and reduced leaflet opening. These patients are able to generate a Vmax more than 4 meters per second, the gradient more than 40 millimeter, and their aortic valve area typically is less than 1 centimeter square, or index less than 0.6 centimeters square per meter square. And these patients usually, their initial symptoms is usually really exertional dyspnea or decrease in their exercise tolerance. And these even precede the classic symptoms of heart failure, angina, or syncope or pre-syncope. So D1 is what we're most familiar with, but also D2 is another important entity. These are symptomatic severe aortic stenosis patients. However, they have low flow, low gradient aortic stenosis because of the reduced ejection fraction. And because of this, they're unable to mount a Vmax more than 4 meters per second or a gradient above 40 millimeter. And these patients should undergo the lobotomy stress echo to try to discern pseudo stenosis from a true aortic stenosis, hoping that you have a contractile reserve in these patients and that their gradient, if it goes above 40 millimeter or their Vmax above 4 meter per second, then you would be diagnosing a true severe aortic stenosis. And these patients obviously would benefit from aortic valve replacements. Stage D3 is a bit more tricky. These are symptomatic severe aortic stenosis, but they are low flow, low gradients, despite the presence of normal ejection fraction. So we call them paradoxical low flow, severe aortic stenosis, and they're unable to mount a gradient above 40 millimeter or velocity more than 4 meter per second because they have a low stroke volume index, which we define as less than 35 cc per meter square. These are usually an entity that happen on older women in particular who have a small cavity and restrictive diastolic filling. And these patients really pose a diagnostic dilemma for the most part. Now, back to the questions regarding this patient. Should we perform an exercise stress test in this patient? And you all got this right. It's a very simple question, but I want to just highlight the recommendations in the guideline pertinent to this choice. Obviously, if the patient was asymptomatic and had a stage C1, so no LV dysfunction, then it would be indicated to do an exercise stress test to attempt to either elicit symptoms or assess the physiological change with exercise. So if the patients have frank symptoms of aortic stenosis on exercise, or drop blood pressure more than systolic blood pressure more than 10 millimeter, or unable to exercise adequately and have limited functional capacity on exercise according to his age and sex, then this patient's may be a good choice to proceed with aortic valve replacements. Now, in this particular patient who had symptomatic severe aortic stenosis, a clear class stage D1 severe aortic stenosis, exercise stress testing should not be performed, obviously because of the risk of severe hemodynamic compromise, including sudden cardiac death and ventricular arrhythmias in these patients. So exercise stress test is obviously not indicated in this patient. What about medical therapy? Is there a role of medical therapy for the treatment of aortic stenosis? So post-TAVI, there are some non-randomized data showing that renin-angiotensin system blockers, such as ACE inhibitor or ARB, may be beneficial because of potential reduction or cause mortality. This is based on registry and observational data. For aortic stenosis, there is no role for statin therapy, particularly in the mild, moderate, and severe asymptomatic stage. Statin therapy does not prevent the hemodynamic progression of aortic stenosis, although many of these patients have concomitant CAD and need statin anyway for the reduction of ischemic cardiovascular events. And in the trials that mostly examined mild and moderate AS patients, there was a reduction in the range of 20% in ischemic events, not in AS-related events. So really, there's no treatment no medical treatment for aortic stenosis. Now, I must submit to you that in stage D3, those with low flow, low gradient aortic stenosis, despite normal ejection fraction, optimizing blood pressure before measuring the gradient and assessing aortic valve severity is a must. These patients should have optimal blood pressure measurements before assessing the severity of their aortic valve. Now, what about measuring aortic valve calcium score in this particular patient? Now, this would not help in this particular patient because he's a class or a stage D1. However, if this patient was a stage D2 or D3, meaning low flow, low gradient, then measuring aortic valve calcium score is reasonable to further define the severity of the aortic valve. So any calcium score more than 2,000 Agastron units in men or 1,300 in women would usually indicate severe aortic stenosis and can serve as an adjunct diagnostic modality to further confirm the severity of the aortic valve. The thresholds are different for women compared to men because in women, there is a strong component of fibrosis in addition to calcification contributing to the aortic stenosis, as opposed to men where calcification is more prominent. That's why there are different thresholds that we utilize. Now, what about following up with echocardiogram in this particular patient? And of course, this patient had stage D1. He needs to go for aortic valve replacement. However, for those patients with stages B and C1, we indicate that follow-up echocardiograms should occur every 3 to 5 years in those with mild severity, every 1 to 2 years in those with moderate severity, and if those patients with severe asymptomatic aortic stenosis, i.e. stage C1, you can follow every 6 to 12 months. And not only echocardiogram follow-up, but of course, clinical follow-up in these patients. So obviously, this patient, straightforward case of stage D1, should undergo an aortic valve replacement. Now, let's go to the when to treat patients with symptomatic severe aortic stenosis, and what are the classes of recommendations that we have in the guideline. We have really 3 recommendations in the 2020 ACC/HA guideline that are all class 1 recommendations to perform aortic valve replacement in patients with severe AS. So for stage D1, you have a class 1 recommendation with a level of evidence A to perform aortic valve replacement. There's a lot of data on this, including the original partner B data that showed in patients who have severe high gradient aortic stenosis, who have no surgical option, TAVI is superior to palliative or medical therapy and prolongs life at 1 and 2 years. Also, we had 2 classes of recommendation. Class 1 for symptomatic low flow, low gradient severe AS with reduced EF, i.e. stage D2. In these patients, aortic valve replacement is also recommended. And likewise, for stage D3, aortic valve replacement is also recommended. However, there's lesser evidence, so non-randomized studies driving these recommendations. However, there is clear indication as a class 1 to perform AVR in any severe symptomatic aortic stenosis, whether D1, D2, or D3. Now, for asymptomatic patients, we have a class 1 recommendation to perform aortic valve replacement in those with stage C2, i.e. those who have LV or RV decompensation, predominantly LV dysfunction less than 50%. Also for those asymptomatic patients with severe AS, but with a preserved LV function, i.e. stage C1, if they're undergoing another cardiac surgery, then also aortic valve replacement is indicated. So these are the 5 class 1 recommendations to perform aortic valve replacement in patients with severe AS, whether symptomatic or asymptomatic. Now, what if the patient is asymptomatic, but have a preserved LV function, so stage C1? We have 4 class 2A recommendations in the guideline to perform AVR in these patients. So as long as these patients are at low surgical risk, despite the absence of symptoms and normal LV function, it is reasonable to perform aortic valve replacement. Mostly here we're talking about surgical aortic valve replacement in the following instances. If the patients have abnormal exercise stress tests, so reduced exercise tolerance, symptoms are elicited, or a drop in the blood pressure on the treadmill. Or if the patient had very severe aortic stenosis. In the guideline, we define this as velocity more than 5 meters per second. Remember, there are even surgical data, small studies showing mortality benefit with SAVR compared to surveillance in patients who are asymptomatic severe AS but have a Vmax more than 4.5 meter per second. Here we choose the cutoff of 5 meter per second in our recommendations. Also, in asymptomatic patients with severe AS but preserved LV function who are at low surgical risk, they have evidence of subclinical heart failure, which we define with a BNP more than 3 times normal. It's reasonable to proceed with surgical aortic valve replacement. And finally, it's reasonable to do surgical aortic valve replacement, provided low surgical risk in patients who are rapid progressors, despite the fact that they have no symptoms and preserved LV function. And we define this as more than 0.3 meter per second per year. This is, again, these are the recommendations and the indications for aortic valve replacement according to the guidelines. So if the patient has an abnormal valve with reduced systolic opening and have symptoms that are attributable to aortic stenosis, we have class 1 recommendations to perform aortic valve replacement, whether SAVR or TAVI, if the patient has stage D1, or if they have stage D2 or stage D3. Understanding stage D3 may pose a diagnostic challenge. Same thing for stage D2, you would want to ascertain that this is a true aortic stenosis, true severe aortic stenosis. Now, to the right hand, if the patients have no aortic stenosis symptoms, it depends on what stage. If they have stage C, true severe asymptomatic aortic stenosis, but they have decreased LV dysfunction, so they already have LV decompensation, then aortic valve replacement is the way to go. It's indicated because these patients already have a reduced ejection fraction and decompensated structural heart disease. Or if they're going for other cardiac surgery, then it's indicated to do aortic valve replacements. Now, if these patients have no LV decompensation or true stage C1, then you can perform a treadmill or assess their velocity if it's very severe, or they have subclinical heart failure or rapid progression, and they're low surgical risk, then it's reasonable to go with SAVR. And then we have a class 2B indication for SAVR for moderate aortic stenosis who are undergoing other cardiac surgery. It may be reasonable to perform surgical aortic valve replacements. So these are really the indications for aortic stenosis and its timing. Now, let's move on to really the choice of aortic valve replacements, whether it's surgical aortic valve surgery, surgical aortic valve replacements, or what we now call TAVI instead of TAVR in the current guidelines. So according to the 2020 Valvular Heart Disease Guideline, the best therapeutic strategy of this 66-year-old man with severe symptomatic aortic stenosis is the choice of therapy is solely dictated by the surgical risk as assessed by the surgeon and interventional cardiologist, or balloon aortic valvuloplasty for palliative purposes, or SAVR with mechanical aortic valve prosthesis, or TAVI, or SAVR with bioprosthesis. And let's start by dissecting these choices. Obviously, choice number 1 is incorrect. Of course, we should invoke the multidisciplinary heart valve team when intervention is considered. We should also calculate individual risk scores. We usually do STS PROM risk score for risk of surgery, as well as a TAVI risk score to inform the patient. But more importantly, it's all done in shared decision-making process with the patients, understanding the patient values, preferences, and also discussing the indication as well as the risk for anticoagulant therapy, which would dictate, and the preferences for its for taking anticoagulant therapy, which will dictate the choice of valve, whether bioprosthetic or mechanical prosthesis. Now, what about aortic balloon valvuloplasty? We have only one class 2B indication based on really expert opinion, saying that in a critically ill patient with severe AS, it may be reasonable to consider aortic valvuloplasty as a bridge to SAVR or TAVI. And I want to submit to you that in a clinical practice, many of those patients, even instead of getting a bridge balloon aortic valvuloplasty, they may go directly for TAVI, given that the risk of the procedure is very comparable. Now, why balloon aortic valvuloplasty is not a definitive treatment option? When it was devised by Alain Cribbé in 1986, we thought that it would be like balloon angioplasty. It would have a very definitive result. However, this turned out not to be the case because, as you may know, the improvement with balloon aortic valvuloplasty improves the aortic valve area from the very severe range to the less severe range, or to barely the moderate range, and the gradients only reduce from 50 millimeter to around 25 millimeter in this meta-analysis that we performed a few years back. So the outcomes are not great with balloon aortic valvuloplasty, and it's short-lived. There's a recoil and restenosis that happens almost definitely within the first 1 to 3 months. And the reason behind that, unlike rheumatic mitral and aortic stenosis, for example, whereby it's a commissural disease, this disease of aortic valve, that calcific degenerative fibrotic disease, is usually a disease that affects the whole aortic valve apparatus and is not treated by a balloon that split the commissure. That's why aortic valvuloplasty is really not a definitive treatment, only a bridge. Now, let's talk about the choice of SAVR versus TAVI in these patients. So we determined that this patient with a class or a stage D1 needs aortic valve replacements. Which way to go? And this is the algorithm that we use in the guideline based on evidence, of course, and we incorporated the risk of the patients as well as the age of the patients. And it's all done in a shared decision-making with the patients and deliberation with the heart valve team. So initially, after discussing with the patient, understanding the patient value and preferences, and discussing with all the stakeholders in the heart valve team, you'd want to assess the risk of surgery in these patients. If the patient have a high surgical risk, i.e. STS more than 8%, or even prohibitive surgical risk, and this could be also defined by very frail patients, multi-organ dysfunction, or if the patient have procedure-specific impediments like radiation or had prior surgery, making redo surgery unsafe. And as long as the patients have a good life expectancy, acceptable quality of life, more than 1 year, and as long as the patient have good peripheral vascular anatomy and have a suitable valve anatomy for TAVI with a transfemoral approach, then TAVI is the way to go. However, the patients is high or prohibitive surgical risk, but have either low life expectancy with good quality of life, or have no transfemoral option because of peripheral arterial disease, then in the guideline we state that palliative care is the way to go. Now, admittedly, in practice, alternative access other than transfemoral TAVI exists, and many of those non-randomized trials showed tremendous benefit, whether it's direct aortic approach, a carotid approach, or even apical approach. This has been done in practice with acceptable outcomes. However, there are no robust evidence showing definitive benefits over medical therapy, and as such, in the guideline, we only included recommendations pertinent to transfemoral TAVI. So again, if the patient have a high or prohibitive surgical risk, as long as they are eligible and can undergo transfemoral TAVI is the way to go. Now, what about if the patient is not at high risk or a prohibitive risk? So low and moderate risk patients. Here you'd want to ask the patient and assess whether they can take vitamin K anticoagulants and there's no contraindication, and they're accepting to take the vitamin K anticoagulants. And if the answer is yes, they're eligible and willing to take Coumadin or warfarin, then you go by patient's age. And here, if the patient is below 50 years of age, you would advise patient to receive a mechanical prosthesis, and as such, TAVR is the way to go. If the patient is above 65 years of age, bioprosthetic, it's reasonable to receive a bioprosthetic aortic valve. And here it could be done with either TAVR or TAVR. If it's between 50 and 65, you can receive mechanical or bioprosthetic. It's reasonable to do either, but TAVR is indicated because of the longevity of surgical bioprosthesis way outweigh the limited data on the longevity and durability of the bioprosthesis of TAVI. Now, if the patient cannot take vitamin K anticoagulants, then bioprosthesis is what the patient has to get. So the first decision-making would be risk first. After you determine that the patient is not at high or probative risk, then you want to see if the patient can take Coumadin or warfarin. Obviously, there's no role of DOAC in mechanical aortic valve replacement cases because of paucity of evidence. So we go by Coumadin or warfarin. If the patients can take those and willing to take those, then you go by the cutoffs of 50, 50 to 65, or more than 65 to determine whether the patient, you would advise the patient to receive a mechanical aortic valve or a bioprosthetic aortic valve. Now, once you determine that the patient is eligible to get bioprosthetic aortic valve, then the determination whether to do TAVR or TAVI come into play. So if a patient have severe symptomatic aortic stenosis, whether it's stage D1, D2, D3, or even stage C2, and have a valve and vascular anatomy suitable for transfemoral TAVI and good age life expectancy, then again, you go by the cutoffs of 65, 65 to 80, or more than 80. So what we say in the guideline, if the patient is less than 65 years of age, TAVR is indicated because of the longevity of bioprosthetic valve with TAVR and the decades of experience with bioprosthetic TAVR. These patients are young. You want to give them the longest durability that's possible with a bioprosthetic aortic valve. And this has been proven for many, many years to exist with TAVR. While with TAVI, we have adjudicated echo data up to 5 years, showing durability of the bioprosthetic TAVI valve, and maybe clinical data up to 8 to 10 years. And this definitely dwarfs compared to the decades of data with showing more durability or durability up to 15 or so years with bioprosthetic TAVR. Now, if the patient is above 80 years of age, then we say it's preferable, it's indicated to do transfemoral TAVI in preference to TAVR, because above 80 years of age, the patient is likely to outlive the bioprosthetic aortic valve that's implanted during TF TAVI. Now, between ages 65 and 80, we give equal footing to perform either TAVR or TF TAVI. Of course, all is done in shared decision-making process with the patients after explaining the risk and benefits and alternatives. Again, let me re-summarize. After assessing the risk of the patient, if the patient is prohibitive risk or high surgical risk and have good quality of life and eligible to transfemoral TAVI, then transfemoral TAVI is the way to go. In those who are low or moderate risk, this is where you need to ask, can the patient take and willing to take Coumadin or warfarin? If that the case is yes, then the cutoffs that we utilize and we advise are 50, 50 to 65, or above 65. So below 50, it's reasonable to proceed with TAVR and choose a mechanical aortic prosthesis. And the reason behind this, there's really, one is the durability of the mechanical aortic prosthesis. And there's really, in this young age group, a signal of survival benefit when you use a mechanical aortic prosthesis because of its durability and obviating the need of redo surgery. Above 65, then it's reasonable to use bioprosthesis over a mechanical valve. And between 50 and 65, you get the choice of either one. Now, once you determine the patient is destined to have a bioprosthesis, then again, you go with the age cutoffs or life expectancy. Age below 65 years of age, life expectancy more than 20 years, TAVR is recommended because of the longevity of the bioprosthesis with TAVR. However, above 80 years of age and the limited life expectancy less than 10 years, transfemoral TAVI is recommended in preference to TAVR, and between 65 and 80 years of age, it's either TAVR or transfemoral TAVI. So in these guidelines, we injected age cutoffs to determine the choice of TAVI or TAVR, of course, while engaging the patient in a shared decision-making process. Now, the European guidelines, by the way, which we just got published 2 weeks ago, and we're now taking more time to digest them, really parallel our recommendations, except that they use a single cutoff of 75 to decide on TAVI versus TAVR, whereby here I think we have more nuanced and 3 cutoffs. And I think, in my opinion, it's more pragmatic and relevant to the practicing cardiologists. Now, there are specific procedure-specific risk factors that no matter what the STS risk score for surgery would preclude the patient from having surgery. These include prior mediastinal radiation, porcelain aorta, also comorbidities that are such as severe COPD and so forth. So the STS score is not the only risk assessment. We also look at the frailty, multi-organ dysfunction, and again, procedure-specific impediments. These are some data we generated with one of our fellows from the administrative database, NIS, showing that there's a improvement in hospital mortality in TAVR versus TAVR in those with a prior mediastinal radiation, for example. So this is a group that's been understudied, and TAVI has been progressively done more and more in the preference to TAVR in these patients. So there's a lot of data generated, not randomized, but from administrative and from a clinical database, showing that in a lot of the subgroups that have not been studied in the clinical trials, TAVI, transfemoral TAVI in particular, have a tremendous benefit over TAVR. Now, I want to remind you of the contemporary outcomes of TAVI. By the way, we used to call it TAVR, and as of December 2020, according to our guideline, we utilize the nomenclature TAVI, transcatheter aortic valve implantation. And these data I'm presenting are from the STS 2019. Actually, this is a temporal trend from 2013 to 2019. And you could see here that early experience, TAVI mortality at 30 days were ranging between 6 to 7%, and currently they're in the range of 2 to 3%. So tremendous improvement in mortality, partly also because we are not only technical advancement and operator experience, but also we are intervening on lesser and lesser risk patients. Stroke rates remain flat at 4%, although I submit to you in the current era, they are in the range of 1% or less. We don't have these data yet. Actually, here are the data. In 2019 for 30-day and 1 year, CMS-linked data showing 2.3 and 1.6% data in real world in 2019. In the clinical trials, they're in the range of 1%. Pacemaker use has been dropping progressively over time, and currently it's around 8 to 10% pacemaker use at 30-day and in hospital, more so with the self-expanding compared to the balloon expandable TAVI platforms. And you want to compare this to the contemporary data pertinent to aortic valve replacements. So remember, isolated aortic valve replacement surgically carries in 2019 mortality rate of 2.2%. So in real world, the TAVI mortality looks very favorably compared to AVR. If you have AVR and CABG, this mortality goes up to 4%, and with dual valve replacement is up to nearly 10%. Now, what are the Achilles heel of TAVI? Paravalvular leak was one of the biggest limitations. However, with the newer generation TAVI, for example, the balloon expandable platform, the third generation had an outer skirt that's long enough to minimize paravalvular leak tremendously. And in some studies, the paravalvular leak really, that's moderate severe, is in the 0% range. There's still maybe trivial to mild paravalvular leak, which has minimal clinical impact, but significant paravalvular leak is really nearly abolished with a newer platform of TAVI. Now, what about those who have mixed valvular disease, such as those with severe aortic stenosis and mitral regurgitation? We did not include any recommendations for doing a mitral clip or transcatheter mitral intervention along with TAVR. What we state that you do TAVI first or TAVR, optimize the patients. I'm talking about the case of severe aortic stenosis and concomitant severe mitral regurg. In these patients, if you could undergo dual valve replacement or SAVR with mitral valve repair, that will be ideal if it can be done safely. If it cannot be done, ideally, would advise to proceed with TAVI, then guideline-directed medical therapy optimization, and then reassess the severity of mitral valve. Sometimes, and oftentimes, those with secondary MR may improve with the reduction of LV systolic pressures with the TAVI, and then you would need a transcatheter mitral intervention. However, if the patient have primary mitral valve disease, or if the mitral regurgitation does not improve after the TAVI and despite optimal medical therapy, then the patient could undergo a staged mitral clip or transcatheter mitral valve intervention. Now, what about the bicuspid aortic valve? We have one recommendation on bicuspid aortic valve in the guideline, and we say it's class 2B. It may be considered to do a TAVI as an alternative to SAVR after considering patient-specific procedure risk values and trade-offs and preferences, provided this is done at a comprehensive valve center. So TAVI for bicuspid valve is really not the front line therapy. SAVR is the way to go in these patients. And the reason behind that, we really outlined in this short review. These patients invariably with bicuspid aortic valve, one, are younger. So you would want to give them a procedure that provides more durability, or for which there is more durability data. That's one. These patients also may have enlarged aortic roots, may need concomitant surgery for the aortic roots anyway, so SAVR may be the way to go. But importantly, they are heavily calcified, so this may carry a higher risk of stroke. And in the early studies, there is also a high risk of paravalvular leak because of the eccentricity of the aortic valve. However, with the new platform, paravalvular leak is no longer a problem with TAVI for the bicuspid aortic valve. There are more and more data, non-randomized, showing really transfemoral TAVI for bicuspid aortic valve provides comparable results to transfemoral TAVI for tricuspid aortic valve stenosis. However, in the guideline, we still maintain a class 2B, may be reasonable to do as an alternative to SAVR, because we're still waiting for the randomized data and accumulation or more data. Let's go back to the case of this young patient who underwent 2 surgeries before and who needed aortic valve replacements. This is one of his 2 surgeries. He had CABG in the past, and this is a pedicle rema anastomosing the LAD, crossing the mediastinum, and looks like very close and adherent to the mediastinum. So redo surgery here would be put the patient at risk of damaging this rema to the LAD. I want you to just look at this ring here and think about it. What's happening at the apex? This is one of our early experiences, actually in 2012. This is an LV gram we performed in these patients. And you could see at the apex, there's a conduit going from the LV apex, it's a valve conduit, all the way to the aorta. So the second surgery after CABG was a surgery for aortic valve stenosis. And this surgery was a bypass from the LV apex with a valve conduit to the aorta, because that patient was determined to be at high surgical risk for redo mediastenomy. So he got a valve conduit, and he came back again after a few years with symptoms of severe aortic stenosis. And we want to determine what's happening with this valve conduit. We here are catheterizing retrogradely from the aorta, the conduit, inserting a wire, putting a catheter there, and want to measure the gradients. And we measure the gradient with the left ventricle and distal to the valve in the conduit, and there was no gradients. We inject dye and we see a hint of maybe anastomosis problem between the conduit and the aorta. And this appears to be where the problem is and where the recurrence of the aortic stenosis symptoms are coming from. There's a failure of this conduit with maybe fibrosis over time of the anastomosis, and this explains the gradient that we observe. There was, I think, a 40+ millimeter gradient across this. So again, this is the conduit, valved conduit, from the LV apex to the aorta, and this is a CAT scan image of the narrowing, a still image by angiography. This we published in Circulation in 2012. This was the first case of TAVI in a patient with a conduit who were treated with a valved conduit for aortic stenosis and have recurrence. And we performed at that time an Edwards Sapien valve implanted. You see here, there's no paravalvular leak or intravalvular leak. And this patient I've been following quite a bit now, doing very well, came with a recurrent ischemic event for which we did a vein graft intervention, and he's doing very, very well. And this is his pre-TAVI gradients. You could see large gradients, delayed upstroke in the central aorta, and abolition of the gradients and appearance of the dicrotic notch, LVDP unchanged, and the patient did very well post-TAVI. Because of the sake of time, I'm not going to go over additional scenarios pertinent to concomitant mitral regurg in patients with severe AS. I only want to say that regarding antithrombotic therapy after TAVI, we now, based on data, state that it's reasonable to proceed with aspirin monotherapy. However, in selective cases, it may be reasonable to use DAPT for a short period, 3 to 6 months, or even may be reasonable to use warfarin for a 3-month period to achieve an IR around 2.5 in selective cases. However, there's no role for DOACs in a patient with TAVI as part of antithrombotic regimen based on Galileo and other clinical trials. Because of the sake of time, I'm going to stop here and happy to take any questions you have. Thank you for your attention.
Thank you, Dr. Jneid. That was a great lecture. I think we have time for about one question. If anyone has any, you can raise your hand or leave a question in the Q&A box or in the chat. I know I had one quick question. I know that there's an ongoing study looking at the outcomes in aortic valve intervention in patients with a heart failure with reduced ejection fraction and moderate aortic stenosis. And you mentioned the patient cohort with bicuspid valve, but I was wondering, do you know any other areas of unclear indication that you think we need to further investigate? I think you're muted.
Yeah, that's a great question, Joyce. So yeah, there are lots of areas for exploration. One is severe asymptomatic aortic stenosis with compensated LV function. Whether TF-TAVI or TAVI in general is beneficial in these remains unclear. By the way, if I'm not mistaken, our European colleagues said that yes, you can do TF-TAVI or SAVR in these patients. However, for asymptomatic patients, we limit our indications to SAVR because of the limited data on TAVI. Severe asymptomatic aortic stenosis is one area that needs to be explored, and there's ongoing studies. Also, moderate aortic stenosis, like you've said, there are studies ongoing. It's going to take a few years for these studies to come on board. By the way, just to remind you now, the mortality with TAVI is in the 1.5% range. So as the mortality comes down with the improvement in techniques and patient selection, really why we should have more impetus to intervene on these patients at a lower threshold. So that's why the trials in moderate aortic stenosis are ongoing, because fixing the aortic valve with a TAVI now is relatively very safe option. Other areas, like you've stated, for patients with stages D2 and D3, there's really paucity of evidence that TAVI is beneficial, and these are areas that really need to be explored. We know that with SAVR, in patients with, for example, stage D2, there's survival benefit and there's improved LV function. We don't have definitive evidence of and symptom relief, obviously, but we don't have as much definitive evidence, particularly for LV function improvement with TAVR in these patients. Same thing in stage D3. Data, we still say it's a class 1 recommendation, but again, there's no randomized clinical trials, and I doubt that there will be randomized clinical trials. And then some of the hot topics and clinical trials that needs really to be explored and done in this field, pertinent to what to do with patients with concomitant CAD and when to intervene in those. So we say it's class 1 to perform coronary angiography, whether CT or invasive in these patients to assess coronary anatomy before TAVI. But if you find significant CAD, what to do? And so this is an area that needs to be studied, and there are no randomized control trial showing impact of or merit of revascularization in these patients before TAVI. The general consensus is probably to intervene in left main disease and those with significant proximal CAD before TAVI, and maybe reserve and do the TAVI, and then reserve the judgment on revascularization for the rest of the anatomy after TAVI. So these are the areas that need to be explored when it comes to TAVI. And then the other thing is TAVI in populations that have been studied in clinical trials. And it's very difficult to study these patients. And a lot of these studies are going to be generated from clinical registries and administrative data. This includes, for example, subpopulations of patients with ESRD, mediastinal radiation, and so forth.
Thank you so much. Well, I think we're just about at time. Thank you, Dr. Jneid, for joining us. And thank you, everyone, for joining us during this cardiology grand rounds. Hopefully next time we can see you all in person.
Thank you. Thank you for that kind invitation.
Okay. Have a great day, everyone.
Thank you.